Welcome to this afternoon's webinar that we call Stronger Together Against HIV World AIDS Day Trivia. So just so you know, this webinar is designed to spotlight the latest progress and ongoing challenges in HIV treatment, prevention, and equitable access to care. My name is Dr. Miranda Ward, and I'm going to more formally introduce myself in a moment, but I just want to first start by thanking the National Hispanic Medical Association, or NHMA, for the invitation to moderate today's discussion. I'm actually one of two speakers that's going to lead an engaging presentation that will end with an interactive trivia that's going to test your knowledge. So that's two speakers, two presentations, two trivia games. And so by participating in today's trivia, you're actually going to be automatically entered into a raffle to win a $25 gift card. And you'll find out if you're the winner no later than a week after the webinar. We just didn't have the logistics to do the wheel and all that, live and during the program. But we're also going to end today's discussion with a lively, moderated discussion. So after both of our presentations that are designed to, inform and motivate you to take an active role in the fight against HIV, you'll get those questions answered basically that moderated discussion. So let's go ahead and head to our next slide. Okay, so now that we've established what you can expect in today's webinar, who am I? So I'm an associate professor and director of equity in the Department of Clinical Research and Leadership at the George Washington University School of Medicine and Health Sciences. And my academic training is in sociology, anthropology, public health, education. So when you put all of that together, I like to think of myself as a social behavioral scientist who does community engaged research on HIV, Black women's health, and youth development. So my work really does sit at the intersection between racism, identity, stigma, and health. And that's definitely the lens that I'm going to bring to today's discussion. So let's go ahead and head to the next slide because I think it's really important for us to share a bit of housekeeping. So as you came on, you probably heard that the webinar is being recorded, and that's because we want to make sure that we reach a wide range of folks. And so NHMA is going to share this recording on their YouTube channel and on their website. You'll also notice that you're muted throughout today's webinar, but we definitely still want to hear from you. So you'll see that there's a Q&A box. So at any point that you have a question, instead of trying to just wait to pose your question, we don't want you to forget, put your question into the chat. And like I said, we have a designated time where we'll actually read through all the questions live in the end and basically answer all of them, in real time. So we go to the next slide. I want to tell you a little bit more about NHMA. You may be new to NHMA, you may be familiar, but just want to make sure everyone understands that it is a nonprofit organization that represents over 50,000 licensed Hispanic physicians in the United States. And so the mission is really to engage empowered Hispanic and other underrepresented healthcare professionals to improve the health of Hispanic and underserved communities. How do they do that? Well, they do that through leadership development, health policy, advocacy, education, strategic partnerships with federal agencies, academic institutions, and community-based organizations across the country. So if you go to the next slide, you'll see that we're going to have, like I said, two presentations. So one, I'm just going to say thank you again for joining us to recognize World AIDS Day, which was actually observed on December 1st, even though today is December 10th. So I'm going to go ahead and start with my presentation. And then what I'm going to do is I'm going to pass things over to Yahaira Rios, who is a Ryan White program coordinator in the Northern Nevada Hopes Clinic. So with that, I'm going to jump into my presentation. We can go to the next slide. All right. So progress and considerations in HIV prevention. So why do I call it this? So ultimately, let's go back to that slide. Okay. So basically, I'm going to be talking about, the biomedical breakthroughs, right? We've had so many advancements in biomedically. But socially, we have not caught up. So those are some of those considerations that I want us to talk about that become ongoing challenges that actually impact all of those biomedical breakthroughs when socially there's still stigma, where there's misinformation, where there's, misconceptions about how do you get exposed to HIV. So, the two really do work hand in hand. And so I want to talk about that. So let's go ahead and head to the next slide. So I think that is so important for us to start off with how do we talk about HIV? Just so you know, we haven't even always called HIV HIV. So back in 1981, we had the very first case of HIV. It was actually called GRID, gay-related immunodeficiency disease. And so as you can see, the reason why I crossed it out is because we obviously don't call it GRID anymore, but that's the thing. The harm has already been done. Even though we now know better, right? Because now we know the science, we know, okay, these are the fluids that actually would expose someone to HIV, right? Whether that is breast milk or blood or rectal anal fluids or vaginal fluids or semen or pre-cum, right? We know those are the fluids. And then notice I didn't say sweat, I didn't say tears, I didn't say saliva, right? Which are those kind of everyday fluids that you come in contact with. So like everyday connections and interactions don't expose you to HIV. Those are the only fluids that actually will expose you to it. That's the thing. Once we learn that, again, GRID, gay-related immunodeficiency disease, had already done its damage. Now people already associate HIV with being gay. And now, now we know, again, these are the fluids, these are the ways that HIV spreads. People still connected to a social identity. So I said we still have our ways to go, even though we know that HIV stands for a human immunodeficiency virus that's disconnected from how you identify. But it is important to know that it is a virus, which means that you do have it for life. And also that it attacks the immune system, which is why it's called immunodeficiency. But the great news is, and one of the things I'm going to kind of underscore in today's discussion, is that we do have antiretroviral therapy that is so effective in basically, not allowing that virus to ravage the immune system in the way it had in the past. Another thing to know is that you know, it's only spread from human to human. So if you ever hear someone saying, oh, doesn't HIV come from monkeys? Okay, the H in HIV is for human. So we know that it's only from one human to the next, right? It doesn't live on a toilet. It has to be, in the fluids of humans and, you getting and being exposed to those fluids. So I think that's just really important that we kind of, emphasize what it's called because that literally has some credibility in actually being able to dispel some of the myths of like, how do you get it and where does it come from? One of the other things that you'll notice is that when it comes to testing, we actually no longer talk about HIV positive tests, right? So now we actually call them reactive tests. So, for those of you familiar with testing, there's lots of like rapid testing, right? The finger prick, the oral swab. And so, if that test is reactive, we do a confirmatory test. And so that's why, clinicians use the term reactive instead of positive. So we since kind of moved away from that and use more clinical language there. We also don't refer to anyone that has a reactive test as HIV positive, right? Oh, they're HIV infected or they're a carrier. No. So it's really important that we use people first language, right? Because no one is their diagnosis. They are a person living with HIV. And in fact, we could actually take out HIV and swap in diabetes. We can say sickle cell, whoever you are living with, whatever you're managing, so important to, humanize folks for, and restore humanity. Because like I said, people are beyond their diagnosis. And then we also don't, use the term someone has full-blown AIDS or they have AIDS. We actually now refer to it as advanced HIV disease because again, you don't die from HIV, you don't die from AIDS. You actually, if you do, have a reactive test and you're a person living with HIV and you're on effective antiretroviral therapy, ART, then you actually can have your viral load so low, we call that suppressed, that you actually won't advance, right, to the later stages of HIV, which now where we would call that, opportunistic infections now, because, remember the immune system is what's getting attacked and like fighting off infections. But if you don't have the immune system because you have like a very low, fire cells, T cells, then yes, you have these opportunistic infections. But these days, if you are on effective treatment, you're not advancing, right? To the point where, if you go to the next slide, we actually are seeing U equals U, right? To the point where when you're on effective treatment, you can have your viral load, like the amount of HIV virus in your system can be so low that it's what's called clinically undetectable. And if something is undetectable in any of those fluids, blood, semen, vaginal fluids, breast milk, then that means that you're not be able to transmit it in those fluids, right? And so that is why that's, I guess, really important. And it actually has come up in our clinical guidelines. So if you go to the next slide, you'll see that one of our first clinical guidelines is around breastfeeding. And so if you are a birthing person living with HIV and you want to breastfeed your baby, and you are on effective, antiretrovirals, the clinical guidelines are in support of you being able to breastfeed your baby because, again, you're undetectable, so it's untransmittable. There's literally less than a 1% chance of transmission. So that's actually a huge biomedical breakthrough in restoring humanity to folks that are living with HIV, right? So you should be able to benefit, you and your baby should be able to benefit from breastfeeding. As we know, the emotional bond, the immunity, helping you lose the weight, like all of the things that come from breastfeeding, you're able to benefit from like everybody else who breastfeeds. But one of the things I will say that we're still kind of challenged by are some of the other guidelines, and this is where some of the work that I do now comes in. So right now there are clinical testing guidelines, and by the way, there are not guidelines for screening, and that's one of the things that I'm working on as a HIV researcher that informs policy. Is that screening is having a conversation, which is really important, right? Because one of the things we want to do is we want to normalize sexual health as health. So, like if you go to see a primary care clinician, no matter why you're there, they're going to ask you a set of questions around depression. Why? Because they're trying to normalize mental health, right? They want to remove the stigma and say, well, we ask everybody these questions. We need to do the exact same thing with sexual health. We need to ask everyone about their sexual activity. And that way, again, no one feels profiled. Like, well, why are you asking me that? Or why are you asking me for an HIV test? We ask everybody this, right? So the screening is so important because, right now there are clinical guidelines around people getting tested. And right now, if you go to the CDC website, you'll see that the recommendation is that anyone between the ages of 13 and 64 should be tested at least once in their lifetime. We need to update that, right? So first of all, there's no reason to have a ceiling, right? 65, 66, 67, you're still alive, right? You're still a sexual being. And, there's the virus doesn't understand age, right? Just like they don't understand like who you're sexually attracted to. So we need to remove identity, right? That's not how the virus works. So it's not about, we need to, that basically is an indication of age bias. When we say, oh, at a certain age, you need to ask them about, sexual activity and therefore you need to test them. No, you still need to test them because you can still get HIV, right? Marital status also doesn't protect you against HIV, right? So one of the things that's going to be really helpful is as far as to pair screening with testing and not leave it to the putting the onus on the clinician to decide who's going to take the test. Just everybody that's sexually active takes it. So that removes, like I said, the clinician bias that may creep in where I'm going to ask this person, but not that person. No, everybody. So that's going to eliminate stigma. It's going to routinize it. And again, normalize these conversations. So we have our work kind of cut out for that. But one of the things, the reason why that's important is because depending on which state you live in, for instance, I live in Washington, D.C., which is an opt-out state, meaning you're automatically going to be tested unless you say no. And so, for example, if I don't have a screening conversation with my clinician and I have a reactive test, now my clinician is placed in a precarious position to have to tell me that I had a reactive test to a test that I didn't know I was taking. So do you see why we should have screening and testing, right? Where I had that conversation with my clinician. I know that they tested me for all of these things. And when it comes time to get my results, I'm ready because I know I got what I got tested for, right? Not to mention, people do have the right to refusal. That's part of patient rights. So that's why screening and testing need to go hand in hand. But if I have a negative test, now I'm a good candidate for PrEP. What is PrEP? Pre-exposure prophylaxis. This is an HIV prevention drug. And by the way, again, going back to biomedical advancements, this drug comes in many forms. You could take it as a daily pill, but you also can take it as a long-acting, injectable. So we can, every 2 to 3 months, or this past Juneteenth, the FDA approved a 6-month version, right? So you only have to come in twice a year, right? So making it so convenient, right? And making it hassle-free. So like, oh, I have to remember to take this every day for, an infection that I don't have, right? It's like, you know what? Just go ahead and stick me. I'm good for 6 months when it comes to HIV prevention, right? So, Of course, they got to do a baseline assessment to make sure your kidneys are good and all the things, right? Before they would prescribe PrEP, and obviously that you would have an HIV negative test result because it is prevention for HIV. If you have a reactive test, you actually need to get HIV treatment, not PrEP, because PrEP is not for those who have HIV. But then we also have what's called PEP, post-exposure prophylaxis. And that basically means if you feel like, you know what, I think I might have been exposed, you have up to 72 hours, right? So 24 hours is like, you want to come in as quickly as possible because like the longer you get to that 72 hours, it's going to be less effective. So, but that's the thing. Right now, the PEP clinical guidelines, clinicians don't, offer it. It's on the patient to be able to know that PEP is a thing and that can go and talk to a clinician about getting PEP. So again, we do have we have some ways to go when it comes to updating the PEP guidelines, but the PrEP guidelines are pretty robust and they're up to date. They just don't include the latest 6 month injectable because it was just FDA approved this past June. But if you go to the next slide, you'll see that the reason why I bring all of this up is because all of this is part of a national strategy. Right now, in the United States, there is a plan to end the HIV epidemic. We call that EHE, end HIV epidemic, okay? And how we're going to do that? By diagnosing, treating, preventing, and responding. So as you can see, again, like I said before, the only way to know that someone has HIV is to, test them. And so, we need to diagnose someone that has HIV as early as possible. So we need to have widespread testing and screening, by the way. And then if someone does have a reactive test, you want to treat them. We want to make sure they get on treatment as soon as possible because, again, we want folks to be undetectable so that they're untransmittable. And so when we talk about prevention, primary prevention is like, okay, just prevent HIV altogether, right? That's where PrEP, comes in. That's where condoms come in, right? So like just prevent you from getting HIV. But if you do have HIV, we want you to prevent you from transmitting it to other people, right? And again, that's where U equals U comes in. But we also want to prevent it from becoming end-stage HIV disease for you. So that's why you want to be on treatment as well and also want to be able to breastfeed if you want to. And so that's where the diagnose, treat, and prevent part of the strategy comes in. But we also want to respond. What does that mean to respond? That means we need to have robust data and monitoring systems because we know that HIV is not evenly distributed throughout the country, right? Not all groups have, the same level of exposure. No. Depending on which group you're part of, that group may be disproportionately impacted, and I'll talk about that in a moment. But also depending on where you live in the country. Like right now, we know that HIV is more concentrated in the South, right? So for all of those reasons, if you have a whole national strategy, you need to be able to allocate resources accordingly to where the data leads you. So as you can see, the goal is to, reduce new HIV infections by 75%. That was our goal for by 2025. That's this year. And then also in the next 5 years, by 2030, we wanted to reduce, new infections by 90%. So before we move on, feel free to add to the chat if you feel like we met. Do you feel like we met our 2025 goal to reduce new infections by 75%? Any takers? Y'all think we met that goal? Let's see if anybody put into the chat. All right. So if you go to the next slide, I'll let you know that we have not. So again, the goal was that we want to, reduce new infections by 75%, which basically rounds out to like 9,000, right? As you can see, we're at 31,000, which means that we're at 40%, right? We did not reach the 75%, so we clearly have our work still cut out for us. And that is because, as you can see in the data, this is the most recently available data on the CDC website, and then the HIV epidemic website, that there are still very, specific subgroups that have, rising number of new cases. And so, that's why, and then not to mention one of the things we're talking about in a moment is some of the things we're still challenged by when it comes to, making sure that we allocate funding, appropriately. So if you go to the next slide, this is why HIV prevention is so important. Because again, remember, we want to reduce new infections, and we have not met our goal. We're at 40% when we say we're going to be at 75% reduction. So we know that PrEP and PEP works, but it's not just about PrEP and PEP, right? Because PrEP and PEP only, prevents HIV. Well, the data shows us that it's not enough to just prevent HIV. We have to also prevent other STIs because having other STIs actually increases the likelihood that you might, get HIV. So, PrEP and PEP only prevent, HIV. If you want to prevent other STIs like chlamydia and HPV and all the other things, we have to use good old faithful ABCs, right? Abstinence, we know, is a foolproof, free, method. Obviously, everyone's not going to do that, but it's still a method that definitely works. Like I said, 100%, right? But for those who are not going to remain abstinent, then that's where reducing the number of partners. Like when we say ABCs, A for abstinence, B for being faithful, C for condoms, right? That's like the public health kind of strategy that kind of came out back in the days. But condoms also, are really effective for preventing a range of other STIs, including HIV, but not limited to HIV. So if we go to the next slide, this is where we again come into our range of observances, right? Because like I said, HIV is not evenly distributed across all groups. So that is why, again, we want to just across the globe, right? Even though I'm talking about our national strategy, HIV impacts, the impact of HIV is felt across the world. So every December 1st, we do have what's called World AIDS Day to recognize and honor the fight, this global fight, and those who have lost their lives, but then those who still have a commitment to ending the epidemic. So that's one. But as you can see, throughout the rest of the year, we want to recognize, okay, we can't have cookie cutter messages. We have to have specific targeted messages for the different groups that are affected differently. Black people, women and girls, youth, Native Americans, right? If you go to the next slide. There are, Latin Americans, gay, people, those who are survivors, those who are aging, right? So, and then again, we also want to focus in on the importance of research around the vaccine, research on, and the importance of testing. So that's why you can see all of these observances are there to kind of really bring around awareness and really some advocacy and policy changes. So with that, let's end with some of the challenges. Funding. Okay, so right now, we're waiting on congressional funding. And as we know, HIV is heavily politicized. And obviously in this country during this administration, there are words that are banned, right? You can't say disparity, you can't say woman, you can't say black, can't say elderly, but those are the populations that are disproportionately impacted, right? So it's kind of like that affects funding when you can't do disparity research. You really can't, hone in on the specific groups and how they experience HIV differently. So funding is a huge ongoing challenge. And as we talk about aging with HIV, some people have been living with HIV, for 20, 30, 40 years. And what does that mean if we say we want, people to be undetectable so they're untransmittable? Well, what if you started off, live as a person living with HIV back in the 80s or the 90s or early 2000s, right? And you started off taking cocktails and we know that the HIV drugs from back in the day were incredibly toxic. Having to take 30 pills a day versus taking the one pill a day. I mean, just in general, there's going to obviously, something that can, kill the HIV virus that's gonna be, toxic. But what does that mean to age with, kind of those therapeutics in your system? And what does that mean to, how does that weigh in on your kidneys? And, as you age, now you have other chronic conditions, right? So there's so much research that needs to go into of what it means to age with HIV. And we know that there's lots of stigma. For those of you familiar with R&B singer Tamar Braxton, she came out publicly on her social media and shared how, she's on PrEP. And you would think that people will be applauding her in in the comments, like, oh, look at you, girl, like, taking charge of your health. That's right, basically, HIV prevention is the way to go. No, people in the comments were like, what? Like, so you really out there like that? Or, oh, I thought PrEP was for gay men. Or it's just, again, it's really just pointed out a lot of the misinformation, misperception, stigma, stereotypes, again, that we really do as HIV educators and advocates still have our work cut out for us. So this is where funding comes in to be able to, have those targeted, tailored messages so that Black women, for example, and that's the group that I work with, know that PrEP is for them, right? That they still do have exposures to HIV, even if they're in a monogamous relationship, right? So all of those things, we need to have those conversations. So I'll go ahead and end there so that we can get into our very first trivia question. All right, the very first question. There are four statements here. Which of these about HIV treatment today is most accurate? Is it A, HIV is curable with current therapies? Is it B, modern antiretroviral therapy can suppress viral load to undetectable levels? Is it C, HIV requires lifelong hospitalization? Or is it the last one, D, antiretroviral therapy must be given intravenously? So as you can see, it popped up for you. Feel free to just click the button, the little bubble for your answer, and then we will do the big reveal. All right, I think everyone has a chance to vote. So let's see. We have a spread. Some said that HIV is curable. Well, we know HIV is not curable because HIV is a virus, so we can't cure it. We can only treat it. And HIV does not require lifelong hospitalization because if you, are on your antiretroviral therapy, then you can live long and end up dying from something else, not even, some of the opportunistic infections. So the answer is modern art or antiretroviral therapies can suppress viral load. Remember, U equals U. Thank you so much for participating in that. All right. So let's go ahead and close that out. Let's go to our next question. U equals U. What does that mean? Universal is unique. Uninfected is unconcerned. Undetectable is untransmittable. And uniting is understanding. All right. So I think everyone had a chance to vote. Okay. So the majority of you are right. Undetectable, right? When you are on your antiretroviral therapy, it's so effective that you have a very, like the load, we call it viral load, is so low that it can't be sexually transmitted, right? So that is a huge milestone in HIV science. And so this is a huge campaign and a huge win for HIV prevention. So thank you for that. All right, let's go to our third question. Y'all are getting good. All right. So it is possible for a mother with HIV to safely breastfeed her baby. True or false? All right. I think everyone had a chance to vote. It is true. And again, like I said, we have brand new clinical guidelines that you can find on the CDC website that, we have science behind it. So remember, all of the science for HIV is robust. Okay. So we have clinical guidelines that are, again, steeped in research, evidence-based research that shows that, again, if you are a woman that is living with HIV, who is, just gave birth and want to breastfeed your baby, and you're on antiretroviral therapy, your viral load is so suppressed. Remember, U equals U, that one of those fluids, right, breast milk, it's actually undetectable and therefore untransmittable. So yes, it is true that they can breastfeed their baby. So we can restore the humanity of, breastfeeding, birthing people who are living with HIV. Love to see it. All right, final question. I think we have one more question, right? Yes. Okay, when is World AIDS Day observed each year? Was it November 30th, December 1st, December 5th, or is it going to be in January 12th? All right, let's go ahead and see. Yes, okay, the majority of you recognize it is December 1st of every single year. So yes, even though today is December 10th, we just wanted to, retrospectively basically observed that World AIDS Day was December 1st. So thank you so much for that. That day is really important because, like we said, it honors those that are affected by HIV and reaffirms our global commitment to ending the epidemic. So with that, I think those are the end of my questions, and I think it might be time for us to pass it over. That's right. Okay, yes. So I'm going to pass things over to Yahida Rios, who's going to reflect on the progress made in HIV treatment and prevention, the recognition of World AIDS Day, which was December 1st. And she's also going to share her insights and experiences supporting people living with HIV, particularly in under-resourced communities. So with that, I'm going to turn things over.
Thank you so much, Dr. Ward. Hello, everyone. Thank you for being here today. I'm really excited to kind of speak about, my experience, especially working with this community and really all the progress that we've made, and also, some bumps that we've been able to kind of hit the road. So like I mentioned, my name's Yahaira Rios, and I've had the privilege of overseeing this program. I oversee the Ryan White program for Northern Nevada Hopes in Reno, Nevada. And so it's so interesting because it's 2 p.m. and it's actually 11:30 a.m. over here, so a little bit earlier. But so I oversee our parts B, C, and D, and oversee the HIV care continuum here in Northern Nevada. So I've been working in this program for about just in the HIV field for about 4 years, so a little bit newer, and I've just been really fallen really passionate about working with this community and just seeing all the advancements and being able to advocate for our community, right? So my background, just to kind of introduce a little bit more, is in social work, and currently working on my master's in social work as well. And really what drew me to this field and ultimately into like HIV services, just understanding that people are shaped by systems, and systems must be shaped by people. So that's really, really important, especially in social work. It specifically taught me really just to see like the macro level change. And so while I really enjoy working, face to face on a micro level with individuals, I also really see how important it is to be in programmatic spaces and policy change and quality improvement on a macro level with the social work lens. So I've really had a lot of great work done with different departments, being able to really put the person first and see how a quick workflow change can really affect the ability for patients to be able to come in. So really being able to be data driven, compassionate, and be that voice in our community, while also really making sure that we're not really affecting people's ability to come into the actual clinic itself. So you can go ahead and next slide. Perfect. So you can next slide. Perfect. Thank you. And so to kind of talk a little bit more about kind of like the efforts and the role that I've been providing into the clinic as well, we really, really highlight, aside from HIV care, we have PC care, but really our clinic started off as an HIV clinic in 1997. So we've been able to make a lot of really great efforts to really be able to reduce that transmission for our community. So really our biggest efforts too is our 48-hour linkage to care and really maintaining that viral load suppression for our patients, and really being able over about 2 decades to be able to continue to have this space and have this environment for these individuals to come in. And so being able to kind of introduce a little bit like World AIDS Day, we recently just had also an event to really bring those patients in, and the community and everyone that's working with this specific community of folks, to have a space where we can also commemorate those that have lost their lives, but also those that are continuing to age, right? So next slide. So I wanted to kind of start off just to provide a historical and significant context of like World AIDS Day, and be able to kind of showcase a little bit kind of where we started to kind of now. So next slide. So World AIDS Day, right, is really more than just a Remembrance Day. It's a call to action. And so it reminds us that HIV is both not just a medical, but a social issue. And we recognize the resilience of people living with HIV and really acknowledge the disparities and the ones that are still impacting care and highlighting really the importance of prevention, early diagnosis, and access to comprehensive services. And, it's really an opportunity for us to recommit to reducing the stigma and create more awareness to ensure that everyone has access and right, they're compassionate, inclusive in healthcare. And it's really important that we educate, right, our providers and different departments. And this is more specifically, I'll be using kind of like the clinic, right, that I work in to be able to make sure the importance of everyone being educated and working with HIV, right, and working with folks that are actively living with HIV. So like right here, it stated 1988, World AIDS Day is first observed, making a significant step into that response into the HIV and AIDS epidemic. Next slide. 1996 was that first kind of strategy where, right, we're able to launch kind of that kind of create more of an emphasis on a federal level to be able to let everyone know, right, like this is something that is important and we are making it a day where we become aware and continue to advocate for HIV and AIDS research and funding. Next slide. During the 2000s, really the World AIDS Day themes kind of started evolving and be able to have a little bit more recognition of kind of the specific factors that we want to focus on within HIV rather than it just be a little bit more generalized. Next slide. In 2022, right, the global theme was really focusing on the resilience and support during COVID-19, the pandemic, and really highlighting those intersecting health crises. So making sure that, right, our patients felt like they were being supported while also making sure that, right, they still had their HIV care, but also making sure that they had access to the clinic during the pandemic. Next slide. And then 2023, World AIDS Day continues to, right, promote awareness and focusing on really having access to healthcare and resources for all communities. And really what that looks like is to be able to reduce those barriers. And really the Ryan White program does that in making sure that we're whether that be a patient is not able to come into the clinic, right? Being able to provide a food voucher or Uber Health so that they're able to come in and really reduce the transmission, reduce those barriers to be able to continue to live a long, healthy life. Next slide. Perfect. So we have our first trivia question. So what year did the US first report the cases that would later be known as HIV/AIDS? Alrighty. Perfect. So the answer is 1981. Okay. Perfect. Next slide. Okay. Okay. There you go. Awesome. So these numbers are really important, especially to being able to really look at when our patients are coming in, right, and seeing the amount of the different percentages, specifically, right, speaking on Hispanic and Latino individuals. So just to kind of read across, there are new infections in 2022, about 31,000. And about 33% of that is Hispanic and Latino individuals. And, going back, specifically working in the clinic as well, this is a population, right, that really is important. Community is really important. So we've been able to look at after the pandemic, we saw a small decrease, right, of folks coming in and really being able to have that opportunity to build that community. And so we've been able to create groups so that folks are able to come in and right talk about their experiences and talk about aging with HIV, specifically Hispanic and Latino individuals, right? And so we see that building these type of groups are really important within community health centers, especially since right patients are coming in and out and they're getting right their labs done, they're meeting with their provider, but sometimes they don't have an outlet to speak about kind of what they're going through or not being able to have a community where they can talk about right their diagnosis just because there's still a lot of stigma in the Hispanic and Latino community. So being able to have an outlet like this has been really, really important. And we've seen an increase, right, in our retention and care numbers and them coming in and being able to feel more like, right, the clinic is a community rather than just a quick in and out to get their medication. And we've really seen an increase in really kind of fostering that environment for those individuals as well. Next slide. Now, really kind of talking a little bit more in depth with Northern Nevada Hope's clinic. Like I mentioned, we started off as an HIV clinic. Next, you can forward 2 slides. So I'll kind of talk quickly through these just because there's multiple slides on this. So like Dr. Ward mentioned, right, a lot of services are really important for patients to come in and really be able to have the opportunity to right get tested or have access to PrEP and PEP, and that is something that we provide to our patients, and we're able to right even to patients that are not coming in to get their HIV services done, we also are able to normalize right being asked and being screened for HIV testing. So that is currently something that we started incorporating in the past 2 years, and that has really helped a lot of individuals and folks feel comfortable with right being able to just get tested. And it's something that right I'm very passionate about in terms of everyone needs to get tested. It does not matter, right, if you've never gotten tested or right if you don't fall within like, oh well, I'm not like right like sexually active. It's like it everyone needs to get tested and needs to be normalized. And so that's something that we've started incorporating within the past years, and that's something where we have seen an increase with HIV testing. And sometimes, right, we get folks that never thought they'd get diagnosed and they get tested. And so they would have never known. And we've caught that, and we caught that on early on. So we show the importance of, right, having this access and having access to early HIV testing. Okay, next slide. And next slide. Okay, so we have another trivia question. People living with HIV who are on effective treatment and have an undetectable viral load cannot transmit HIV sexually. This is a true or false question. Correct. So this is kind of speaking on that U equals U principle, undetectable equals untransmittable. And this is really something that's really, really important. And, you know, this is something that I kind of preach to everyone whenever I talk about, right, folks living with HIV or just in general people, right, who don't know much about HIV is really folks, and especially when I would work with individuals, this is a moment for folks to really get their autonomy back in their life, right? When I before taking on the program, I worked one-on-one with individuals with patients, and one of the biggest things was like, right, like they're like, oh no, like they just start Googling things and they're like, well, I don't know if I'm going to be able, right? They start thinking about their life, their future. And then when I talk about, right, U equals U and what does that mean? And being adherent with your medication really, really does take their autonomy, their control back into their own life. So it's really, really important. That's something that we always kind of stress on with working with our patients and our providers and right all the departments working with this population, and right the importance of it, right? Because for example, some of our behavioral health therapists may not know right before a lot about like HIV and working with patients living with HIV. And so we provided that education. So now during like their therapy, they're able to have these conversations because they have that education rather the patients just hearing this from their case managers or their provider. They're also hearing it from like their MA, their Ryan White nurse, their therapist, right? And so it's really all a collaborative help for everyone. So next question, next slide. Okay, perfect. So kind of spoke a little bit about our medical care for HIV patients, and it's really it's really important for us as soon as someone gets diagnosed. We, aside right from working through the Ryan White program, we really it is important for us to link them to care within about 2 days and make sure that they have everything they need, whether that be right getting signed up for the Ryan White program, medication if they transfer from another state, making sure that we have all their medications down. And the cool part about the clinic is that we really wanted to focus on making sure to reduce barriers of like them going to another location to get like their labs done or pick up their medication. So we have a pharmacy and we have our clinic, our labs, our behavioral health and case management all in one clinic. So that really has helped a lot of our patients just be able to make like a one-stop shop at the clinic and get everything they need done, and makes it easier, right? Because they know all of the providers that they're actively working on. Next, next slide. I kind of spoke a little bit about our mental health services as well, which is I just like to highlight because, right, a lot of our patients are sometimes isolated, and we work with a lot of our population is aging, and so they need this type of support too, and be able to have an outlet. And so we have seen an increase of folks making sure that they're being retained to the clinic when they're linked to mental health services. So that'd be a provider, a peer support specialist. Next slide. Um, our case management also, that is something that we are able to provide. And since we receive Ryan White funds, we have Ryan White case managers that are specifically helping White with their eligibility and their supportive services as well. Next slide. I kind of talked a little bit about the Ryan White program, but really kind of what I like to emphasize this, especially with our patients, is that there's always some type of support. Ryan White was kind of like a quick summary was a young boy, right? He got transmitted with AIDS through blood transfusion, and right, his family were huge supporters of Ryan White, of HIV and AIDS research and education. There was a piece of legislation that was passed, and that kind of created the foundation for funding for that. But really, aside from Medicaid and Medicare, Ryan White is their largest payer source for patients in terms of medication too. So that is a huge help for our individuals, and really it provides a lot of funding for right like case management, housing, behavioral health, transportation. So all of these little things factor into getting the patients to come in and making sure, right, more than anything that their healthcare is the top priority too. Next slide. Next slide. So I'm gonna kind of go through these fairly quick, and I'll talk about it because I know we have about less than 10 minutes. But to kind of discuss a little bit about the different things that have helped too is really outreach and education, testing and diagnosis. So I'll try to kind of summarize a little bit the next kind of 3-4 slides, which is really it's important. We've seen the increase of awareness in our community when we go and have like right outreach events to different community health events or to the university here, the schools, to be able to create and normalize, right? Since if we create an environment where we are having these conversations, then folks, right, will be more inclined to ask questions or right, like the same thing with screening and getting tested with HIV. So really making sure that everything is we're able to provide as much information as we can to our community while also making sure that we're providing the answers and kind of um taking right answering questions that could be that could have some stigma or have some stereotypes. And right, I always let folks know right ways that you actually can transmit the virus and ways that you actually can't. So that's a very important factor when working in community services. Next slide. Uh, next slide. Next slide. Okay, so I believe this is going to be our last question, which is which group of services is included in the federal Ryan White HIV program? Perfect. All of the above. Awesome. And then you can go ahead, since I already kind of spoke about all of these things, you can go all the way to policy, advocacy and policy. Perfect. So aside, right, from all the work that we're constantly doing in our community, we're also, right, things can't change, right? If sometimes the policy just is not there to help. So we are in our healthcare facility, we also are able to right advocate for policy change and be able to go speak and talk about the experiences and things that we are going through with our community and our population because it's very important, right, that they our representatives hear exactly what our real time things are happening in right with our population and things and barriers. So this is something that we also are very passionate about in terms of our program, but also as a clinic. So that is something that we not only do changes within our clinic, but we also seek for policy changes and advocate on a state level as well. Um, Alrighty. And then perfect. So I believe I already kind of summarized and spoke everything just because I want to be cautious of your guys' time. And I know we still have a couple of trivia questions at the end. So you can go ahead and um, go all the way to trivia. Perfect. Awesome. So our first trivia question is, what type of virus is HIV? Give you guys a few minutes.
So this is going to be our last question because we won't have time to go through the rest of the trivia questions. So thank you so much, everyone, for answering this question. The type of virus HIV is. Just go ahead and show the response, and then we'll jump into some resources. Okay, so the majority of you do recognize that it is a retrovirus, which is why we call the treatment antiretroviral, because it's attempting to attack the retrovirus, which is genetic material in the DNA that makes it incredibly persistent, but that's why it's really important that someone who is living with HIV maintains their treatment regimen so that they can keep it under control. So with that, if I can ask the host to skip past the rest of the trivia questions, and we're going to just make sure in the 3 minutes that remain that we thank you. Perfect, perfect. All right. So, thank you so much, everyone, for joining us and participating in that trivia. Like I said, if you did participate in the trivia, your name is, been entered into that raffle, so you can expect, to hear from us in HMA if you are the winner. Also, thank you to Yahida for sharing such detail on the Ryan White program and the experiences in preventing HIV. I just wanted to highlight a few important resources and next steps. This first one is from the CDC. We just want to share some tools and information from CDC's Let's Stop HIV Together campaign. These resources are available in English and Spanish and are designed to support prevention, testing, treatment, and a range of diverse communities. And if you can actually just take these materials and share them with your networks. Whether you're in public health, you're in education, you're in advocacy, all of these materials are free, easily downloadable and ready to use. So if you go to the next slide, we do hope that you will stay engaged with NHMA through upcoming events. And so you see a couple of, QR codes on how you can, basically register for some of those upcoming events at the top of the year. If you go to the next slide, we do have some socials that you can follow. So NHMA, if you don't already follow, is on Instagram, it's on LinkedIn, Facebook, Threads, and so it's really important to stay connected because that's how you're going to know about any of the events or initiatives that they have underway. If you go to the next slide, you also can access downloadable resources and more information at hispanichealth.info, which is basically a bilingual health education hub. So we definitely want to share that as a resource. On our next slide, if you're not already a member of NHMA, we invite you to consider joining. This is a huge, important network. And that is, you could be a clinician, you could be an advocate, you could be a student, you could be a community leader. It doesn't matter who you are. There is a place and a role for you with NHMA. So on our next slide, just before we close, I did want to highlight a valuable resource that NHMA offers, which is the job board. Excuse me. So whether you're seeking your next career move or you're looking to recruit top talent, this platform connects job seekers with over 400. That's right, you heard that right. 400 active employers and features more than 13,000 postings. So for employers, it provides access to 19,000 searchable resumes and more than 3 million total profile views. All you have to do is scan this QR code that you see on the screen, or you can just visit the website and explore opportunities and connect with others in the network. So our final slide, and we're exactly at 3 o'clock. We just want to thank you so much for joining us today. Remember, we're stronger together against HIV. That concludes our program. Thanks for joining.
Thank you all.